Did you know that your pancreas is already at work before you even take your first bite of food? The simple act of smelling or seeing a meal can trigger secretions that prepare your body for digestion. Yet, most people don't realize how central this hidden organ is, not just for breaking down food, but also for controlling blood sugar and keeping your entire digestive system in balance. Today, we're diving into the fascinating world of the gastrointestinal system, with a spotlight on the pancreas. We'll explore how the GI tract, made up of the mouth, esophagus, stomach, small intestine, and large intestine, works together as a team, and why the pancreas plays such a critical role in the process. Have you ever wondered how your body can take something as complex as a steak, a slice of bread, or even DNA from your food and break it down into tiny building blocks that fuel your cells? Or why the pancreas produces both enzymes for digestion and hormones for metabolism? Stick around, because by the end of this video, you'll not only understand how these processes work but also why they're essential to life itself. When we talk about digestion, it's easy to imagine only the stomach at work. But in reality, the gastrointestinal system is an entire coordinated network, stretching from the mouth all the way to the large intestine, with each segment performing a unique role. It all begins in the mouth, where mechanical chewing and saliva enzymes start breaking down food. The esophagus then transports this mixture down to the stomach, which acts like a muscular blender, mixing food with acid and enzymes. But here's the surprising part: most of the digestion and nutrient absorption doesn't actually happen in the stomach. Instead, it takes place in the small intestine, which is often called the workhorse of digestion. Inside the small intestine, starches, proteins, lipids, nucleic acids, and other complex molecules are dismantled into their simplest forms: sugars, amino acids, fatty acids, and nucleotides. These tiny molecules can then be absorbed into the bloodstream, where they provide fuel and building blocks for every cell in the body. Without this breakdown, the nutrients in our food would remain locked away and unusable. But digestion isn't just about enzymes doing their job. It's a highly regulated system. Different organs and chemical signals coordinate when, how, and what gets digested. The stomach, pancreas, intestines, and even the nervous system all send signals back and forth to maintain efficiency and protect the delicate lining of the gut. In this video, we'll not only explore the normal physiology and biochemistry of gastric and intestinal function, but also touch on what happens when things go wrong, pathological changes that can lead to serious intestinal diseases. We'll also review the key tests used to evaluate gastrointestinal and pancreatic function, bridging the gap between biology and clinical practice. Now that we've seen how the gastrointestinal system works as a whole, let's shift our focus to two of its most important supporting organs, the pancreas and the liver. Even though the pancreas sits outside the GI tract, it's absolutely essential for digestion, acting as both an endocrine and an exocrine gland. The pancreas is often called a dual-function organ. Its endocrine tissue, made up of the islets of Langerhans, produces hormones like insulin and glucagon, which regulate carbohydrate metabolism and keep blood sugar levels stable. Without this precise balance, the body could not manage energy effectively, leading to conditions like diabetes. On the other side, its exocrine tissue plays a direct role in digestion. These cells secrete powerful digestive enzymes, packaged in a watery fluid rich in bicarbonate. This fluid travels through ducts and is released into the duodenum, where it helps break down proteins, fats, carbohydrates, and nucleic acids into absorbable molecules. Think of it as the biochemical toolkit that allows the small intestine to actually finish the job that started in the stomach. While the pancreas does the heavy lifting with enzymes, the liver is equally critical for digestion, though in a slightly different way. The liver produces bile, which is stored in the gallbladder and released into the duodenum to help emulsify fats, making them easier for pancreatic enzymes to digest. Beyond digestion, the liver also detoxifies harmful compounds and manages nutrient storage, topics that deserve their own deep dive, which we'll cover in a separate video. Together, the pancreas and liver form a powerful partnership, working seamlessly with the rest of the GI system to ensure nutrients from food can be broken down, absorbed, and put to use by every cell in the body. The pancreas may be small in size, but its structure is remarkably complex. Weighing between 70 and 105 grams, it rests quietly in the upper abdomen, tucked behind the peritoneal cavity. Anatomically, it lies near the first and second lumbar vertebrae, slightly above the navel, and curves snugly against the duodenum, the very first section of the small intestine. This strategic position allows it to release enzymes and fluids directly where digestion begins in earnest. The pancreas is made up of two very different tissues, each with unique responsibilities. The endocrine portion, though smaller, is incredibly important. Scattered throughout are clusters known as the islets of Langerhans, which contain specialized cells that release key hormones, insulin, which lowers blood sugar, glucagon, which raises it, as well as gastrin and somatostatin, which help regulate digestion and hormonal balance. But the exocrine tissue makes up the bulk of the pancreas. These cells produce between 1.5 and 2 liters of enzyme-rich fluid every day. This secretion flows through a network of ducts into the duodenum, arming the intestine with the tools needed to break down food into absorbable nutrients. Though compact, the pancreas is truly a multitasking organ, perfectly positioned and equipped to keep digestion running smoothly. When most people think of digestive juices, they picture stomach acid. But the fluid secreted by the pancreas is very different, and just as essential. Unlike the highly acidic gastric juices of the stomach, pancreatic fluid is clear, watery, and strongly alkaline, with a pH that can reach up to 8.3. This alkalinity comes from its high concentration of sodium bicarbonate, a compound that plays a critical defensive role. When the acidic contents of the stomach, known as chyme, empty into the duodenum, they could damage the delicate intestinal lining. To prevent this, bicarbonate from the pancreas immediately neutralizes the acid, creating a safe environment where digestive enzymes can work effectively. The composition of pancreatic fluid is carefully balanced. Its sodium and potassium levels are very similar to those found in blood serum, but its bicarbonate and chloride levels shift in opposite directions, always totaling around 150 millimoles per liter. This fine-tuned chemistry ensures that the small intestine remains protected without disrupting the body's overall electrolyte balance. Far from being just water with enzymes, pancreatic fluid is a highly specialized secretion perfectly engineered to prepare food particles for breakdown while safeguarding the intestine from corrosive stomach acid. If the pancreas is the toolbox of digestion, then its enzymes are the individual tools, each one designed for a specific task. These enzymes transform large, complex food molecules into small, absorbable units that the body can use. Let's start with proteins. The pancreas produces a range of proteolytic enzymes, including trypsin, chymotrypsin, elastase, collagenase, leucine aminopeptidase, and carboxypeptidases. Each targets different peptide bonds, working together to dismantle large protein molecules into amino acids and small peptides. Without them, dietary proteins would pass through the intestine largely intact, unusable to the body. Next, consider lipids, or fats. Fats are notoriously difficult to digest because they don't mix well with water. Here, the pancreas provides enzymes like lipase and lecithinase, which break fats into glycerol and free fatty acids. These simpler molecules can then be absorbed through the intestinal lining and reassembled into usable energy stores. For carbohydrates, the star of the show is pancreatic amylase. While salivary amylase in the mouth begins starch digestion, pancreatic amylase continues the process in the small intestine, breaking complex carbohydrates down into maltose and simpler sugars that can be absorbed as glucose. Finally, the pancreas even helps with nucleic acid digestion. Enzymes like ribonuclease and other nucleases break down the DNA and RNA from food into nucleotides, the building blocks needed for cell repair and genetic processes. Altogether, these enzymes act like a demolition team, reducing complex food into simple, absorbable nutrients. And because they are secreted in inactive forms, they only activate once safely inside the intestine, preventing the pancreas from digesting itself. This orchestration of enzyme activity is what makes the pancreas such a vital player in the digestive system. So far, we've seen what the pancreas produces, but how does it know when to release these powerful secretions? The answer lies in a sophisticated balance of nervous and hormonal control. On the nervous side, the vagus nerve plays a key role. Even before food touches your tongue, simply smelling or seeing a meal can trigger mild enzyme release from the pancreas. This prepares the digestive system for the work ahead. Once food reaches the stomach, signals intensify, prompting greater secretion into the small intestine. But the real fine-tuning comes from hormones. The most important is secretin, which is released when acidic chyme enters the duodenum. Secretin stimulates the pancreas to release its bicarbonate-rich fluid, neutralizing the acid and protecting the intestinal lining. Interestingly, secretin also has a modest effect on reducing stomach gastrin activity, ensuring the system doesn't get overwhelmed with excess acid. Another key hormone is cholecystokinin, or CCK. This is secreted when fats and amino acids arrive in the duodenum. CCK acts on the acinar cells of the pancreas, causing them to release enzyme-rich fluid. Together, secretin and CCK coordinate the delivery of just the right mix of enzymes and bicarbonate, matching the chemical needs of each meal. Without this dual regulation, digestion would be chaotic and inefficient. Over 95% of all pancreatic disorders, excluding traumatic injuries, can be traced back to just three conditions: cystic fibrosis, pancreatic carcinoma, and pancreatitis. Together, they dominate the clinical landscape of pancreatic disease, affecting both the endocrine and exocrine functions of this vital organ. The pancreas is often described as having a dual personality. On one side, it regulates blood sugar through hormone production; on the other, it supplies powerful digestive enzymes that break down our food. When pancreatic diseases strike, they disrupt one or both of these systems, leading to complications ranging from malabsorption and weight loss to severe abdominal pain and even life-threatening metabolic crises. Now, we'll take a closer look at the major diseases of the pancreas, starting with the genetic condition cystic fibrosis, moving on to the deadly but common pancreatic carcinoma, examining islet cell tumors that alter hormone secretion, and then diving deep into pancreatitis, a painful and sometimes recurrent inflammatory process. Finally, we'll explore malabsorption syndrome, which highlights just how essential the pancreas is for proper nutrition. Cystic fibrosis, or CF, is one of the most well-known genetic disorders, and it has a profound impact on the pancreas. It follows an autosomal recessive inheritance pattern, meaning a child must inherit two defective copies of the gene, one from each parent, to develop the disease. The gene responsible is the CFTR gene on chromosome 7, and more than 900 different mutations have been identified. CF is not rare. It occurs in about 1 in 1,600 live births, with particularly high prevalence among Northern European populations. In some regions, such as Brittany in France, the carrier rate exceeds 10%. The hallmark of CF is thick, sticky secretions due to abnormal chloride and water transport in epithelial cells. This dysfunction affects mucus and exocrine glands throughout the body, leading to multisystem complications. In newborns, CF may present as intestinal obstruction, while in children, recurrent pulmonary infections are common. In adults, the pancreas is frequently affected, with symptoms of malabsorption, though this tends to appear later in life. Pathologically, the pancreatic ducts and acini become dilated and clogged with mucus, forming cyst-like structures. Because the pancreatic secretions cannot flow properly into the duodenum, enzymes fail to reach food, leading to impaired digestion. Over time, progressive fibrosis and scarring replace healthy tissue, further reducing pancreatic function. The result is chronic malnutrition, poor growth, and digestive difficulties despite adequate food intake. Fortunately, modern medicine has made strides in genetic screening, allowing for early detection and intervention. Today, newborn screening programs and targeted therapies have significantly improved survival and quality of life for patients with cystic fibrosis. Pancreatic carcinoma is one of the deadliest cancers known to medicine. In the United States, it ranks as the fourth most common cause of cancer-related deaths, claiming around 38,000 lives each year. What makes this disease so concerning is not just its prevalence, but its silent progression and poor prognosis. Epidemiologically, pancreatic carcinoma occurs slightly more often in men and in African American populations. By the time most patients are diagnosed, the cancer is already advanced. The 5-year survival rate is only about 6%, and the majority of patients die within a year of diagnosis. The vast majority of these cancers are ductal adenocarcinomas, arising from the pancreatic ducts. The pancreas-rich nerve supply contributes to one of the most striking symptoms: severe abdominal or back pain. Tumor location plays a major role in detection. Tumors in the body or tail of the pancreas often remain unnoticed until late stages, because their symptoms are vague and nonspecific. By contrast, tumors in the head of the pancreas are usually discovered earlier, since their proximity to the bile duct causes obstructive jaundice. Patients may present with yellowing of the skin, clay-colored stools due to low fecal bilirubin, and dark urine. Other common symptoms include weight loss, anorexia, and persistent nausea. However, these are nonspecific and can mimic many other gastrointestinal disorders, making diagnosis especially challenging. Importantly, physicians must always rule out other causes of biliary obstruction before confirming pancreatic cancer. In short, pancreatic carcinoma is a stealthy and aggressive disease. Its late detection, rapid progression, and resistance to treatment make it one of the greatest challenges in oncology. Unlike pancreatic carcinoma, which arises from the ductal cells, islet cell tumors originate from the endocrine portion of the pancreas, the islets of Langerhans. These tumors are less common but clinically important because they can dramatically alter hormone secretion, leading to striking metabolic effects. The most frequent type is the beta cell tumor, or insulinoma. These tumors secrete excessive amounts of insulin, causing hyperinsulinism. The result is recurrent episodes of low blood glucose, which may present as dizziness, confusion, sweating, or even hypoglycemic shock if severe. Another significant type is the gastrin-secreting tumor, known as a gastrinoma. These are associated with Zollinger-Ellison syndrome, a condition characterized by excess gastric acid secretion. Patients typically experience recurrent peptic ulcers, abdominal pain, and even watery diarrhea due to the overwhelming acid load in the gastrointestinal tract. Far rarer are glucagon-secreting tumors. These tumors increase circulating glucagon levels, often leading to diabetes mellitus because of impaired glucose regulation. Patients may also experience weight loss and skin rashes associated with glucagon excess. While not as common as carcinoma or pancreatitis, islet cell tumors highlight the pancreas' critical role as both an endocrine and digestive organ. Their symptoms may mimic more common conditions, which can delay diagnosis. However, because their effects are linked to specific hormones, recognizing the characteristic syndromes, like hypoglycemia or recurrent ulcers, is the key to early detection. Pancreatitis is one of the most dramatic and painful diseases of the pancreas. It occurs when the organ essentially begins to digest itself, a process triggered by the reflux of bile or intestinal contents into the pancreatic duct. This sets off a cascade of autodigestion, inflammation, and tissue injury. There are three main types. Acute pancreatitis develops suddenly and, if managed properly, may resolve without permanent damage. Chronic pancreatitis is more insidious, marked by irreversible injury and scarring that progressively impairs function. Recurrent pancreatitis lies in between, presenting with repeated attacks that may evolve into chronic disease. Pathologically, several key events unfold. Fluid may accumulate in the retroperitoneal space, lowering circulating blood volume and leading to shock. Acinar cell necrosis and hemorrhage damage the pancreas directly, while fat necrosis within and around the gland consumes calcium, often causing hypocalcemia. Over time, fibrosis and loss of acinar cells severely compromise the pancreas' ability to function. Clinically, the hallmark symptom is sudden, severe abdominal pain that radiates to the back or flanks. The pain is relentless, often accompanied by nausea and vomiting, and can last for days to weeks. Some patients also experience fever and signs of systemic inflammation. The causes of pancreatitis are numerous, but two dominate: chronic alcohol abuse and gallstones. Other contributors include hyperlipoproteinemia, hyperparathyroidism, mumps, pancreatic tumors, pregnancy, trauma, and even certain drugs or post-transplant reactions. Laboratory findings help confirm the diagnosis. Amylase and lipase levels rise dramatically in acute pancreatitis. Triglycerides and calcium may also be elevated, especially in metabolic causes. Conversely, severe cases show low calcium due to fat necrosis and low protein levels from plasma leakage. Tissue hypoxia further complicates recovery by reducing blood supply to already damaged tissue. Pancreatitis is not only painful, it is potentially life-threatening. Severe cases can progress to multi-organ failure. Long-term, recurrent or chronic forms may lead to permanent malabsorption and diabetes as the pancreas loses both exocrine and endocrine capacity. In short, pancreatitis represents the most acute example of the pancreas turning against itself, an inflammatory storm with both local destruction and systemic consequences. When the pancreas loses its ability to secrete digestive enzymes, the body can no longer properly break down and absorb nutrients. This condition, known as malabsorption syndrome, is a direct consequence of severe pancreatic exocrine insufficiency. One of the earliest and most recognizable symptoms is steatorrhea, bulky, greasy, foul-smelling stools that float and are difficult to flush. This occurs when more than 5 grams of fat per day remain unabsorbed and pass into the stool. Patients often complain of bloating, abdominal discomfort, and an urgent need for frequent bowel movements. Over time, malabsorption leads to progressive weight loss, regardless of how much food is consumed. Because the pancreas normally breaks down proteins, carbohydrates, and fats, all three macronutrients become poorly absorbed when enzyme production is lost. This results in both energy deficiency and nutritional deficits. Importantly, malabsorption doesn't just affect calories, it also causes widespread micronutrient deficiencies. Fat-soluble vitamins A, D, E, and K are especially vulnerable, leading to night blindness, bone weakness, easy bruising, and neurological problems. Minerals, electrolytes, and water are also poorly absorbed, further compounding the problem. In some cases, malabsorption presents as more isolated deficiencies. For example, inadequate absorption of vitamin B12 may cause megaloblastic anemia, while lactose intolerance results in diarrhea and bloating after consuming dairy products. Other diseases can mimic or worsen pancreatic malabsorption. Biliary obstruction, which prevents bile from emulsifying fats, and small intestinal disorders, which impair absorption directly, are common culprits. Ultimately, malabsorption syndrome reflects the devastating consequences of a pancreas that can no longer perform its digestive duties. Without enzyme replacement therapy and nutritional support, patients face progressive weakness, poor growth, and even life-threatening deficiencies. The pancreas might be a small organ, but when it malfunctions, the consequences can be enormous, ranging from digestive problems to life-threatening diseases like pancreatitis or pancreatic cancer. But how do doctors actually test the pancreas? And what clues in our blood, stool, or even sweat reveal what's really happening inside this hidden organ? That's exactly what we'll explore in next section, pancreatic testing, how doctors detect pancreatic dysfunction and uncover disease. Testing is usually triggered when something suspicious shows up, like elevated enzyme levels, signs of malabsorption, or unexplained digestive symptoms. From there, physicians rely on a wide variety of specialized tests, each designed to reveal a different piece of the puzzle. Broadly, pancreatic tests fall into four main categories. Malabsorption tests, such as stool fat exams, the D-Xylose test, and fecal fat analysis. Exocrine function tests, including secretin and CCK stimulation, or enzyme activity checks. Obstruction tests, where bilirubin levels help detect extrahepatic blockages. Endocrine tests, looking at hormones like insulin, gastrin, and glucose. In the sections ahead, we'll break down these tests one by one, showing how they work, what results mean, and why they're essential for diagnosing pancreatic disease. One of the most direct ways to assess pancreatic health is by collecting and analyzing the fluid it secretes. This isn't as simple as a blood test. It requires stimulating the pancreas and then performing duodenal intubation to capture the secretions as they flow into the small intestine. So, how do doctors stimulate pancreatic activity? There are a few different approaches. Test meals can provoke secretion in a natural way. Secretin is often used because it directly triggers the release of bicarbonate-rich fluid. A combination of secretin and cholecystokinin, CCK, provides an even clearer picture, stimulating both bicarbonate and enzyme secretion. Once the fluid is collected, it's analyzed for volume and flow rate, showing how well the pancreas responds. Bicarbonate concentration, crucial for neutralizing stomach acid. Enzyme levels, including amylase, lipase, and trypsin. Even cytology, which can reveal cancerous cells. This test has some big advantages. It directly measures the pancreas secretions, offering a window into both function and pathology. However, it comes with limitations. It's invasive, can't precisely pinpoint where a tumor is located, and isn't useful for identifying mild or past episodes of pancreatitis. Because of advances in imaging technologies like CT, MRI, and endoscopic ultrasound, direct pancreatic fluid testing is now less commonly used. But in certain cases, it still plays a vital role in helping doctors understand the pancreas at its most fundamental level. The secretin/CCK test is considered the gold standard for measuring the exocrine capacity of the pancreas, the part responsible for producing digestive enzymes and bicarbonate. Here's how it works. Before the test, the patient fasts for at least 6 hours. A tube is then carefully placed into the duodenum to make sure that only pancreatic secretions are collected, avoiding contamination from the stomach. Next, the stimulation begins. Doctors may inject secretin through and 4 at a dose of about 2 to 3 units per kilogram, sometimes followed by cholecystokinin, CCK. In some cases, a higher dose of secretin alone is used. These hormones mimic what normally happens after a meal, signaling the pancreas to release fluid rich in enzymes and bicarbonate. Over the next 30 to 80 minutes, secretions are collected, either in 10-minute intervals or as one pooled sample. Once collected, they're analyzed for several important factors. pH levels, showing how alkaline the fluid is. Flow rate, or how much fluid the pancreas produces. Enzyme activity, including amylase, trypsin, and lipase. Bicarbonate concentration, which helps neutralize stomach acid. In healthy individuals, bicarbonate output is about 15 mol per hour in men and 12 mol per hour in women, with normal fluid production at around 2 milliliters per kilogram. When the results fall outside these ranges, doctors can pinpoint specific problems. For example, low fluid volume but high enzyme levels often indicates an obstruction, like a blocked duct. Low bicarbonate and low enzyme levels suggest chronic pancreatitis, cystic fibrosis, pancreatic cysts, or edema. Although invasive, this test provides a precise measurement of pancreatic secretory capacity, making it an invaluable tool when imaging alone doesn't provide clear answers. One of the most important ways to check for pancreatic insufficiency and malabsorption is through fecal fat analysis. Normally, the digestive system breaks down and absorbs dietary fats efficiently, with only a small amount passing into stool. But when the pancreas isn't functioning properly, large amounts of fat escape absorption, leading to a condition called steatorrhea. Fat in stool comes from several sources: unabsorbed dietary fat, bile-excreted fat, shed intestinal cells, and breakdown products from bacteria. In healthy individuals on a normal diet, stool fat is usually 1 to 7 grams per day, with a composition of roughly 60% fatty acids, 30% sterols and alcohols, and 10% triglycerides. When fat levels rise significantly, it points to malabsorption. This may be due to pancreatic insufficiency, but diseases of the small intestine or biliary obstruction can also cause abnormal results. There are two main approaches to fecal fat testing. 1. Qualitative screening, Sudan staining. This is a quick, simple test where stool is stained with fat-soluble dyes like Sudan 3 or 4. Under a microscope, fat droplets can be counted. Normally, you'll see about 40 to 50 small droplets per field, but in steatorrhea, the number and size of droplets greatly increase. If meat fibers are also present, the problem often originates from the pancreas. 2. Quantitative fecal fat test, the gold standard. For a precise diagnosis, patients eat 50 to 100 grams of fat daily for at least 2 days before and during collection. Stool is gathered over 72 hours, refrigerated, and then analyzed. The fat can be measured using gravimetric methods, where total lipids are extracted and weighed. Titrometric methods, which measure saponifiable fats but tend to give slightly lower results. If stool fat exceeds 7 grams per day, it confirms malabsorption. This test remains the most reliable way to identify pancreatic insufficiency and track disease progression. When it comes to diagnosing cystic fibrosis, CF, one of the hallmark tests is the sweat chloride test. While it's not pancreas-specific, it plays a crucial role in confirming CF, a genetic condition that often causes severe pancreatic dysfunction and malabsorption. The principle is simple. People with CF have abnormally high levels of sodium and chloride in their sweat. In fact, in over 99% of patients, both sodium and chloride concentrations are 2 to 5 times higher than normal. The diagnostic cutoff is well established. In children, a sweat chloride level greater than 60 millimoles per liter is strongly diagnostic. In adults, levels above 80 millimoles per liter almost always confirm CF. No other condition produces chloride levels this high, making the test highly specific. So, how is the test performed today? The most common method is pilocarpine iontophoresis. A mild electric current is applied to the skin, usually on the forearm, to drive pilocarpine into the sweat glands. This stimulates sweat production, which is then collected and analyzed for chloride concentration. For accuracy, the test is usually repeated. In the past, older methods involved wrapping patients in plastic or using collection bags, but these carried risks of dehydration, electrolyte imbalance, and overheating. Thankfully, modern techniques are safer and far more reliable. It's worth noting that while sodium and chloride are reliable markers, potassium levels may also rise in CF patients, but they are not diagnostic. Another limitation is that the test cannot distinguish between CF carriers and those without the gene mutation. When doctors suspect pancreatic disease, one of the first things they check are serum enzyme levels, especially amylase and lipase. These enzymes leak into the bloodstream during pancreatic injury, providing valuable diagnostic clues. Let's start with amylase. It's the most commonly tested enzyme for acute pancreatitis. Amylase levels rise within just a few hours of onset, peak at about 24 hours, and usually return to normal within 3 to 5 days. This quick spike makes it an excellent early marker. However, there's a catch: amylase levels don't always correlate with the severity of pancreatitis. A mild case might show very high levels, while severe disease might show only moderate elevations. To improve accuracy, physicians often calculate the amylase clearance to creatinine clearance ratio. Normally, this value is under 3.1%. In acute pancreatitis, it can rise to around 8 to 9%, making it a stronger indicator. Still, false positives can occur in conditions like burns, sepsis, or diabetic ketoacidosis. Now, what about lipase? Historically, it was less used due to technical limitations, but today it's considered highly valuable. Lipase rises around the same time as amylase in acute pancreatitis, but here's the advantage: lipase stays elevated longer, often several days beyond amylase normalization. This makes it especially helpful for patients who come to the hospital late after symptom onset. Both enzymes can also be elevated in non-pancreatic conditions. For example, amylase may rise in mumps, gallbladder disease, liver conditions, ruptured ectopic pregnancy, or even benign macroamylasemia. Lipase can increase in bone fractures or fat embolism. The key takeaway is that while serum enzymes provide early and useful diagnostic information, they must always be interpreted alongside the patient's clinical picture and imaging studies for an accurate diagnosis. And that is all for today. Don't forget to like, share and subscribe. If you have any questions, leave it in comments. See you next time. Bye.